Hello.
Hi. Welcome. All right. This is the crew. Sweet. So I'm just going to go ahead and get started since it's noon. It will be recorded online, so I appreciate the people joining us online. Do feel free to sort of interject from home as well if you have any questions about any of this material. Again, today really is sort of the first one of this kind of lecture series, which I'm trying to make a part of our clinic. Part of why I'm doing this is because I believe strongly that just highly reliable health information, especially maybe directly from your doctor, is something that's lacking in healthcare, and and especially in primary care, where I really believe strongly that what we do with our lives, the way we think about health, what we do with our habits, are really the primary form of quote unquote medicine, really, that we should all be employing in our lives. And again, as a physician, I do prescribe medicines. I do a variety of procedures. Those all have a big role in medicine as well. But sometimes I think we all forget that there are some really basic things that we can be doing with our health that maybe lead us to a life where we don't need to use as many of those other tools that we have, right? So again, many of you may have heard this, but you may say this during appointments, but I'm very much a yes and, right? So exercise and maybe take, a cholesterol medicine or whatever it is else, right? But not an either or, right? So we want to use, we want to recognize what tools we have available to us, maybe for thousands of years, right? And then we also want to sort of think about how we can use those in concert with some of our more modern tools in medicine. So you'll see as I go through the presentation, hopefully what that means is somewhat clear. We'll just kind of dive right in. I think most of you know who I am. I'm Dr. Rahman. I go by Shuman mostly casually. Like I said, for those at home or for anyone who's looking at this in the future, the intention is that this is just an educational self-study, and that the knowledge here is really applicable to, let's say, 95, 99% of people is sort of my goal. Okay. Welcome. So I'll kind of jump to the first slide here. Just talk a little bit about our objectives for today. So again, if we're talking about primary care and health, right, I think health means a lot of things to a lot of people. So I'm not here to define health for everybody. I'm just here to sort of give you my definition of health and what it is. I think that everyone, hopefully, who's coming here, we can all have sort of a shared goal, and to be explicit about what that is, which is increasing health. Really, we have to kind of define what health is. Okay, so that's kind of one of my big objectives today. How is it that we all can assess our health, either with help from me or maybe even just on your own? Okay. I've sort of marketed and sort of said, hey, I really am sort of, longevity is one of my niches within primary care. What does longevity even mean? So just discussing a little bit about what is longevity, what is health span, what are some of these terms that you may hear me use in both my material and maybe during appointments. Again, part of this is the just educational kind of tools, right, that we all have to increase flourishing. I put flourishing in there instead of health, just because to make it a little bit more applicable to everybody. I think everybody, would agree that they would like to flourish. So hopefully, otherwise, probably no point in employing me. And again, how to use this clinic specifically to its fullest, right? So what services do we have here? How is it that maybe I'm a little little bit different than what you'll find at an insurance-built clinic or sort of your mainstream medicine clinics. And then certainly kind of just to brush on a few topics to get, keep interest and engagement here. So part of what we'll sort of do is just touch base a little bit on a few things, and with the knowledge that, hey, if you have questions, you want more in-depth information, yes, we will have specific sessions around a lot of the components that are in this lecture to do more deep dives, as you'll see, kind of into like things like cardiovascular health, cancer health, etc. So what is health? Let's just dive right into that, right? So, and again, like I said, we can all have our personal definitions. This is something where I'm just trying to say, maybe this is our shared definition of health within the clinic here. Health can certainly contain much more, or even maybe, maybe not quite too much less. But again, there's some personal aspects here. I'm not trying to say that this is the only definition. But I think some ways to define health is a lack of illness, right? So you don't have any major chronic illnesses that are really debilitating you or may shorten your life. Kind of on that note, right? So that is sort of a key feature of the difference between something like health span and lifespan. So health span is simply defined as the period of your life where you're free from chronic disease and disability. Right, and I think we all would want to make it a goal to expand our health span, and that is what longevity medicine really gets at, is trying to maximize health span. A lot of people think about it maybe as in reference to lifespan, which is purely just the number of years you live, and really doesn't account for the quality of life or the functionality you may have there in that lifespan. That's not what that's getting at. And when I personally am talking to people about longevity and longevity medicine, it is really purely at not necessarily getting at expanding lifespan. While many of the things we do will do that, what we're really shooting for is a much more functional measure, which is something like health span, right? And that's really my goal, is that maybe you only live another year or two, but the quality of those last years, I think we can definitely make much higher by doing, by sort of future planning and thinking about things in a little bit different way. So what does that look like? Again, I would say my goal for my patients is that they're physically functional, right? So they have freedom of movement. They're not bedbound, maybe using the least amount of assisted devices as possible. Mentally flexible, right? So this is getting at, again, something happens in your day that's unexpected. Is that totally blowing up your entire day? Now you can't get back on track for a week, right? That would be maybe inflexibility, right? So we're talking about stress tolerance, the ability to kind of engage in new behaviors, change certain behaviors, even think about what does that look like? Again, just maybe having that flexibility, the openness to consider other things as real possibilities, right? I would say that this is at least beginning to define what is kind of mental health. Okay, meaningful social interactions. Again, many people don't necessarily think about their social lives as a part of their health. But again, I would say that that's sort of short-sighted. We're very social animals. Even if you're sort of, quote, introverted, we have to sort of have social interactions in our lives. I think the vast majority of at least do, really, to have good health outcomes. And also, this is very connected to mental health. I think people understand that. But I think more and more we're understanding the biology of social interactions, and that it may actually even drive quote unquote physical diseases. Okay. And so a sense of drive and purpose. I think this gets missed sometimes in our medical system as well, right? So we're busy. We got 14 minutes to go over your 7 medical problems. Many doctors don't have the time to even address what does this even mean? Why are you here even, right? And again, I think once you start to think about this, you can see how that can definitely impair or promote some of these other behaviors. Acknowledging the limitations of our biology. Again, I would say this is something that I certainly can help people with, right? That is my job, right, is to sort of understand human biology to the best of my ability at this time. And again, I kind of tell people, look, you're the expert on your body, right? But I am somewhat an expert on human biology, right? And together we can come up with something much more meaningful than either one of us alone, right? With no patients, then, what does that knowledge really do? Maybe it helps me, right? But then I'm not a doctor. I'm just someone who has a bunch of health information. So, and again, planning for knowns and unknowns, right? So how do we plan for an unknown thing, right? That's sort of an interesting concept. So we'll kind of expand on what exactly I mean by that here in a second. But all that to say that, part of longevity medicine, I think, is recognizing that we all age and that aging is a real phenomenon, right? And that it will happen if you're lucky enough to stay alive. And with aging, that there is an average level of decline of everything, whether it's cognitive ability, physical ability, several things. Hormone profiles change. So much changes in our body, right? And some things will happen unexpectedly, and we'll sort of talk about, well, what can we do to account maybe even for those situations? So that's what I'm kind of getting at planning there. And again, if anyone has questions, please just interrupt, okay? So kind of first we'll talk about a little bit how to assess health. Some of these things, what I've really focused on here is some of the aspects that I feel like are maybe lacking in our overall system, and what I'm trying to do more uniquely, let's say, to assess health. And I'll talk about some of the evidence behind some of these things. So you can see we have 4 categories here. So physical. And to be clear, let me just make a comment. Even though I'm dividing things in health, into some of these categories, I just want to be clear that, your body, brain, etc., it's one functioning system. We only really have one health, right? We don't have physical health that is separate from mental health, that's separate from, our self-awareness of health or circadian rhythm issues. These are all integrated systems. But again, to communicate effectively, yes, I am breaking these down into sort of, reductionist type, sections so we can discuss each one. So physical. So what are some things that I think, again, get missed and that are sort of my goals to understand health more deeply? VO2 max. Okay, so functional assessments are basically things that sort of in the physical world assess what you can do with your body. Okay, so this would be like, if you're weightlift, maybe something like what's your 1 rep maximum, right? So I'm focusing on things that have really good evidence to support that they are a window into your deeper health, okay? So VO2 max, which is a measure of blood gases. So what at maximum exercise capacity, what is your ability to take in oxygen and make energy is what that number is telling you. How efficient is your heart and lung system at getting oxygen in so that you can actually produce energy to do physical work? That's what the VO2 max is telling you. And what we see in kind of when you track this number against all-cause mortality, so death from any cause, what we see is that this is one of the most strongly tied elements of the sort of biomarkers per se to overall mortality. So basically what I'm telling you is that the higher your VO2 max is, the less likely that you're imminently kind of going to maybe die of any cause, okay, is what statistically that's telling you, right? So that's a pretty impressive kind of marker there, right? So again, this is something that most people sort of say is for elite athletes. There's no reason to check numbers like this and just your lay person. And I would very much disagree, right? Because this is absolutely modifiable all the way into your 80s and 90s. And I think there's very good evidence that if you are increasing this as you're aging, that is a sign that you are absolutely increasing your health, okay? Grip strength is a very similar story to that. So again, almost gets tested nowhere, right? But what we see is that people that have maintained grip strength as they age, that is a very good sign that otherwise internally they're doing very well and very healthy. Okay, and this is something that can be trained too. So simple training for grip strength might be just dead hang. So hanging from a bar, farmer carry, something like that, carrying weight. Okay, so there's some simple ways to do that. Zone 2 output. So I know that a lot of you may have heard, that are my patients have probably heard about Zone 2 exercise, kind of that level of exertion where you're feeling at the edge of breathlessness is what that is defined by. Scientifically, Zone 2 is actually the level at which you're exerting enough and creating lactic acid, which is one of the main waste products of your muscles, at a rate to where your body can process that lactic acid, get it out of your body. You're creating enough to where it's slightly elevated, but it's sort of at equilibrium, meaning that you're producing and excreting lactic acid at about the same rate. Okay, and that's what zone 2 is getting at. And what we see is that what you can do in zone 2 is a very good marker of overall metabolic health, right? So again, I said that most people, that's going to be that edge of breathlessness. That's the best way to tell. Over time, what we see is that zone 2 capacity can definitely increase. I'll just give you an example. Even myself, maybe compared to like an elite athlete, right? They may be able to output something like 400 watts on a bike and barely be breaking a sweat and barely hardly breathing. Whereas if I'm on a bike trying to do 400 watts an hour, I might be passing out. Okay. So they're in zone 2. I'm probably in zone 5 or 6, right? So that sort of thing. Again, that's, you can see how that's an important marker of health. Laboratory assessments. So these are also kind of in that physical. So again, some things that I see, you know, lacking in many other aspects of healthcare. You know, we're not necessarily making accessible genetic profiles to make people understand a little bit more deeply what is their genetic profile predisposing them to, so we can have some future planning around, hey, you know, if you have an elevated cancer risk or heart attack risk, or et cetera, right, we may want to be more aggressive with an prevention program from an earlier age, right? Many of our kind of profile, or many of the ways that medicine is working these days is we're really treating everybody to a population average, right? So a lot of our scientific data sets, right, they're really telling you about averages about large populations. You know, I think what sometimes is lacking is how thinking critically about how we can make that average fit you specifically, right? Are you different? Are you similar to the people in this study? What are your specific genetics contributing to this sort of risk profile? And that's where I'm getting at sort of risk-specific biomarkers, right? So some things that you guys have probably seen me do that many other physicians don't do are things like the ApoB instead of your LDL, you know, checking things like homocysteine, uric acid, other biomarkers that we do believe sort of represent maybe a deeper root cause of some of the diseases that people deal with, including things like, you know, even joint pain, hypertension, diabetes, right? You know, and even contributing to heart disease there. And then microbiome is something that is, you know, sort of up and coming in our scientific literature around how to use the microbiome to increase health. But again, I would say that many, you know, clinics don't even offer this sort of assessment, right? So again, I'm trying to offer some things that I certainly believe are getting at some of the root causes of our diseases and problems, rather than, you know, a lot of what medicine is doing these days is just treating symptoms, treating the outcome of what the disease is, rather than what's actually causing these diseases. So mental health, again, super important. A little bit harder to have objective measures, so we do rely on subjective experience. That's not to say that that's not reliable. It's just a little different than getting a lab draw that has an exact value, right? So we use surveys, we use things like weekly check-ins, we use journaling, right? And this is certainly an area where, you know, this is about what are you practicing, right? Mental health is sort of a practice. It's a daily lived kind of thing, right? So just kind of pointing out that that's always kind of changing and evolving. In fact, all of these things are circadian. So again, I think this is a really interesting, fascinating area of research that's coming out now, where, you know, we're realizing that many of our organs respond to very circadian signals. So people kind of know about circadian rhythm in relation to sleep. Okay, so I put sleep-wake there, but actually our liver has certain clocks that are dictated by when and we're eating and when we're not eating, fasting. Okay, light and dark is also kind of one of the biggest triggers for this, right? And actually, so on that note, right, so many people know about melatonin. What we don't know about melatonin, or maybe what many of us don't know, is that melatonin receptors exist throughout the body, in the pancreas, in your muscles, okay? And so clearly biology has, you know, kind of kept these things here for some quote unquote reason, for lack of a better way of saying that, right? But again, living in a way that's in concert with what our bodies are sort of tuned to detect is what I'm getting at here. So some of us have to work shifts or do other things for periods of our lives, but just thinking about, am I living in concert with the fact that we're on a rock hurling around the sun at a very regular period, and that everything here on this earth is really attuned to that signal? Okay. And self-awareness, I'd say this is a nice little caveat right into that. So, again, you're having an experience, you're having certain feelings. Maybe some of those are good, some of those are bad. How do we tease out, what these mean? Are emotions reliable markers of mental health? Are, physical aches and pains reliable markers of, actual injury, right? So this is a hurt versus harm kind of discussion, right? And again, just kind of exploring that and just introducing this concept, right? Some people are maybe so disconnected from the way they feel, they don't even realize that, okay, when my emotions sort of flare up, yes, my joint pain is worse, and that also affects my sleep, and then it sort of all cycles back, right? And just making those connections that, yes, things like your feelings, things like your sleep patterns can absolutely be connected to why maybe you're experiencing more or less pain, or maybe why you had a better or worse outcome, with a particular procedure or intervention, etc. Right? These things really do matter. And then the responsibility comment, I mean, I think this is really big, right? Just realizing that your health is not dependent on me or anyone else, really, right? That it's dependent mostly on you and what you do. And that is not to in any way to say that I cannot help you. Obviously, I wouldn't be standing here if I thought that. But that this is a team effort, right? That there's certain things that if you're not sort of engaged and involved, that I will never be able to overcome that, right, to help you. So just kind of pointing that out and making that obvious. So personalized primary care. So what does that mean, right? So this is a term that I see sort of thrown around a lot, especially in kind of these newer functional medicine, direct primary care kind of clinics. So I just want to define what this means to me, okay, in regards to my patients. So one, I mean, I think it's definitely a proactive approach, that is, so meaning that we're not going to wait for something to become an ailment to rise to the level of a critical medical problem to intervene, right? I think it's much more important to prevent things than it is to react to those things. That's not necessarily personalized so much as just a general approach that I believe in. But kind of framed by your specific life goals and driven by your specific body's data is what I'm getting at here, right? So I'm not just going to put everybody on a cholesterol medicine because I know cholesterol causes heart disease. We're going to get your specific cholesterol level. We're going to get into what is your family history, what is your desire for prevention here, et cetera, et cetera. And those all are the elements that are really going to drive whether we choose a cholesterol medication or whether we don't, or use some other lifestyle factors. I think personally, again, I really think that these concepts that Dr. Peter Attia talks about in his book Outlive, as well as his podcast called The Drive, of the centenarian decathlon and sort of the 4 horsemen of death. I'm going to go into depth about what these mean. I think these are extremely important concepts. And again, how is that tied to personal health care? Well, as I define the centenarian decathlon, you'll see that those are goals that are very specific to what you want to do in your life, right? And then we work backwards from there to make sure that we can accomplish those goals. And the 4 horsemen applies to everybody. Basically, it's the 4 most common causes of death. But again, thinking about those 4 things in relation to your personal risk factors, your labs, your genetics, your family history, right? And having a proactive plan to combat these things that are, killing, let's say, 70+% of our population, especially as we age. Okay. Lifting the scale of expensive healthcare, right? So I think we've all been misled to believe that some of these personalized tests, looking at labs in depth, spending more time with your patient, that this is impossible because the healthcare system's it's all too expensive. We're all overburdened. And again, I think that's true in certain places, but As you know, many of my patients have seen, the lab panels I do may include 10, 15 labs, and we're not even breaking $100, sometimes not even breaking $50 for this blood work. If you guys are aware of my prices, my highest tier is $90 a patient per month for kind of the oldest population that we see. And I would argue $1,000 for a year of healthcare is pretty darn cheap, you know, compared to certainly what insurance policies are charging you. And again, you know, some of these tests that they deny, MRIs, DEXA scans, other things like that, we have access to sometimes for a third, a tenth of the cost of what they even cost when they're, quote, approved by insurances. So I've had several people tell me that they paid $2,000, $3,000 for an MRI. Under my contracts, these things cost about $200, $250 for an MRI. X-rays in the less than $100 range, usually about 50 bucks. CT scans, again, in sort of that between $100 and $200 range, depending on a few factors there. But again, no, I think we have access to really affordable healthcare once we shed the red tape and sort of the inflationary pricing model of insurances and cut out that middleman. I don't think that some of the kind of practical things we need to do in healthcare are really that expensive. And again, one of my big goals is to, and why I even became a family doctor is this line right here, is forming a deep patient-physician relationship, right? So I looked at a few other specialties, and ultimately at the end of the day, that ability to follow you up, to actually have a year-long, you know, years-long relationship, to see children grow up to adults, to see, you know, people add members to their family, maybe lose some loved ones, right? And to be there for those types of situations is something really special and unique that a family doctor has an opportunity to do with their patients. And I would say that's one of the main reasons I picked this specialty. So when I saw medicine trending to cut my appointment time shorter and shorter, add more patients to my day, and again, salary wasn't going anywhere. They were just telling me that's what's required to keep the salary, right? I just really couldn't be on board with that. So again, just offering something where you can maintain that kind of old school, model of medicine where your doctor maybe came to your house or ate dinner with you or other things like that. But having a little bit more personal relationship with that family doctor at least. And I think community is something that's also very important to me, at least personally. So as you guys can see, we're all gathered here together. I don't know many other doctors' offices that maybe have social gatherings like this. But I think that's something that, again, as I shared, I think that social experiences are an important part of health in our lives. And I think that, again, part of this is that I don't have all the knowledge. I have not experienced some of the diseases that my patients experience, right? But if I can be a facilitator to help those patients help each other, then that's another aspect of maybe what's lacking in our medical system, is allowing people to share what's worked for them and maybe not, right, through a physician-led kind of group. So lots of people go to other support groups or something like this, but to have your doctor there to bounce ideas off of, and for me to actually learn from you, right? I mean, there's sort of a selfish reason I want to do this too, that, you know, again, certainly I would learn a lot from my patients and continue to do that. Okay, so one of the first concepts I was going to jump into is this 4 horsemen of death. I do give, again, Peter Attia kind of credit for this, and it's sort of outlined in more detail in his book and podcast, as I mentioned. But what are those 4 things? You can see that, again, they're not necessarily the 4 leading causes of death, but they sort of are if you think about it in a way. So number 1, cardiovascular atherosclerosis. So you can see when we look over at that chart, that accounts for heart disease, as well as number 5 there, stroke, which is also really due to the same disease process. So number 1 basically is the deposition of cholesterol particles in the walls of your blood vessel. Depending on what area of that body that happens, we either call that heart disease, we call that potentially stroke, we can also call that peripheral vascular disease. So some people have blockages in their legs, and that's what that is. Just as for sort of numbers go, you can see how much of a burden of disease this is. And actually, you can see from 2020 to 2021, actually that rate increased. Okay, so while we've done a lot of miraculous things with medicine and really improved heart disease with our anti-tobacco programs and with the advent of things like cardiac cath and heart stents, things of that nature, we've really dropped that mortality rate, but you can still see it still remains number one. Okay, so that's number one. Number two is cancer. Cancer is not necessarily one disease, right, but sort of a umbrella disease that describes your own body genetically mutating in such a way that these cells have lost the ability to control their replication. Okay, so some sort of cell is replicating sort of unregulated. Once that starts to spread from the organ of origin, that is basically turned into a deadly disease, right? So most cancer will kill you because it metastasizes, or it's because it's growing on a critical structure. But again, just thinking about cancer in a more unique way, thinking about screening in a more personalized way, I think is something that we're kind of getting at here. Number three is neurodegeneration. So we're going to kind of skip over COVID and intentional injuries. Those aren't things that we really have a ton of control over, right? So we're really trying to talk about the things we do have control over. And then you can see that, let's see, Alzheimer's is right there after chronic respiratory diseases, right? And why is chronic respiratory disease not on there? Again, because the vast majority of those deaths are attributable to smoking. And again, if you smoke, don't smoke, right? That's all I have to say about that. And certainly we can help you more with that. But that's why I didn't put COPD on there, because it's largely sort of a self-inflicted injury there. Neurodegeneration, dementia, right? So this is a wide variety of diseases, of the number one of which is Alzheimer's dementia, and certainly a huge cause of death and disability. And then number four is diabetes and related diseases, which I've put into a sort of an umbrella category of metabolic dysfunction. Because again, I think if we're waiting to the point where you're diagnosed with type 2 diabetes, we've lost over a decade of time to reverse the root cause of what's called insulin resistance, right? So that's why I kind of call it metabolic dysfunction, because really we want to intervene when you start to show signs of insulin resistance, not when your A1C changes and now you're sort of dabbling into type 2 diabetes, to be clear. Type 1 diabetes is exactly the opposite, where your body makes no insulin, not necessarily resistance, but lack of insulin. Okay, so that's kind of our four horsemen of death. And again, when we're talking about this in relation to personalized medicine, what I'm really advocating for is that everyone understands their risk within each one of these categories, and that everyone has a at least idea of where they can start with prevention of each one of these major disease categories. So what is Peter Attia's centenarian decathlon, right? So this is a concept of basically, so, he's very a goal and objective, right? So if we're training in our lives and using exercise as a tool, right, then what is it that maybe we're training for? And that's where this concept comes in. So centenarian decathlon is saying at 100, what are the 10 things that you would like to do, be able to do with your body and mind, okay? And we don't all have to sort of entertain that we may or may not live to 100, right? So he talks a little bit about, hey, look, just think about in the last 10 years of your life, whenever that may be, okay? What are the types of things you want to do? Hopefully that's at a ripe old age, right? So we're talking about some things like pick up your grandchild or your great-grandchild, okay? Hike Skyline Drive, maybe, place your roller bed, not need help getting on an airplane or putting your bag in an overhead bin. Okay, maybe go fishing if that's what you like, right? Or, and this list can go on and on. And again, as you can see, should be very personalized to some of the things that you want to be able to do with your body. And then sort of as a direct corollary of this, right, we would use sort of an exercise called backcasting. So instead of forecasting, we look into the future, say, what is it we want in the future? And then we sort of backcast that and say, okay, I'm 50. I know that each decade that passes, I will have X percentage decline of muscular strength, cognitive ability, VO2 max, etc. right? So if you're starting now at 50, barely able to do a goblet squat with, 15, 20 pounds, which is basically the movement that's going to be required to bend, lift your grandchild up, then you may as well cross that off your list. I'm sorry, you're not going to be able to do that when you're 80 or 90 years old, right? That doesn't mean that that's not modifiable, but maybe that means that if you want to be able to lift that grandchild, maybe we need to start doing some, exercise now to ensure that the strength decline that you have in over the next 30 years is not so great that you can't do that, right? So again, it's just a way to frame some of these future goals, and then also to give you that power over the now to realize that, yes, what you do now absolutely impacts your ability to reach that goal or not, right? That we are not powerless to the phenomenon of aging. We can account for this and still be able to really ensure to the best of our controllable ability that we can still do these things when we're older. Okay, and this is sort of a different concept, but I threw that in there as sort of functional reserve, right? So what we see, like, let's say, and this is sort of planning for the unexpected, right? So what we see is that if you can train in a way that accounts for some of this decline, right, not only will it account for the decline and help you meet those known goals, it will also help you have this what's called functional reserve, right? So that when maybe you do have that unexpected car accident, unexpected heart attack, unexpected this, that cancer diagnosis, right? That maybe that's the difference between being able to tolerate that event, get back on your feet, and get back to what you were doing versus that happens and now your life is dramatically different. Maybe you're chronically debilitated, maybe you've lost some mental capacity, right? But I do see that this is very, what you do prior to that injury very much dictates what your life looks like after. That's not to say that people can't start from a maybe lower position and actually build after an injury. I think that's absolutely possible too. But again, just taking that proactive approach, I think we'll all end up in a better place than that reactive approach. So labs. So I mentioned some laboratory assessments. Let's just talk a little bit about labs for a second. Yes, get them. Okay, so I always advocate for once a year labs. Some people will ask me, I'm relatively healthy. Do I really need blood work? And I would say absolutely. There's some things that show up in blood work, maybe sometimes years before it really manifests as a symptom or otherwise detectable problem. So I do think there is a lot of value in at least once a year looking at labs. And I would say kind of this is maybe a message to my young, healthy population. I think people with medical issues want their blood work, right? Many people who are sort of younger and healthier maybe do a lot of things to try to increase their health or stay healthy, right? I still believe that labs have a role in their lives, and even if it's just once a year. Understanding normal values, right? So when we're looking at labs, often LabCorp puts this fancy H or L and some coloring next to our labs. And I just want people to understand that that does not mean you are normal or abnormal, right? What most labs actually tell us outside of labs that are just kind of positive, negative, right, is where do you fall in a population curve? Right, so let's take a blood count, for example. We check your red blood cell count and we say, okay, quote, normal is between, and I'm actually talking about hemoglobin here, so let's use those numbers. Normal might be somewhere between 12 and 15, okay? Does that mean if your hemoglobin is 11.8 that now you definitely have disease and you're going to drop dead in the next hour? Absolutely not, right? What that means is that your hemoglobin is outside the 10 to 90% range of a healthy population, right? So if it's on the lower end, then I'll say, okay, you're in the bottom 10% of people that that are quote unquote healthy, right? And we have to ask the question, does this mean you have disease or not, right? So an abnormal lab basically tells me you're on sort of the tail ends of the population. And again, in concert with how you're feeling, all of your other blood work, that's what really determines is it normal or not. So I just want to point out that, again, when people are sort of looking at their laboratory data, if they see something high, low, et cetera, outside of range, yes, that does raise, at least you should pause and ask the question, is something going on? But that does not mean that the answer is definitely yes, okay? And then again, framing this data through the lens of our objectives, right? So not just do we want to get blood work, but we want to then look at that blood work and understand what those numbers sort of mean in relation to our health goals, in relation to something like the centenarian decathlon, some of our functional goals, etc. Or maybe they're not involved, right? And that may be the case too, but just understanding how those numbers can really affect your life and what those what changes in those numbers might mean as far as, are you doing well or are you not? Are you progressing or are you maybe getting worse in a certain category? And that's really what that intervention follow-up is, right? And this is something that just bothers me to no end, right? Insurance companies, you'll get a vitamin D, and then you start vitamin D, you try to check a second vitamin D, and they said, you already did one this year. Nope, we're not going to approve that, right? So when we have an intervention, right, it's very important to me as your doctor to try to be objective in that, okay, we did this, let's see if that fixed something. Not only can we maybe use your experience, I believe that we should probably use your experience and some scientific data too. And again, this system really allows me to do that with absolutely no barriers other than maybe a few bucks of blood work. Okay. And again, limitations, what I'm getting at is really that labs don't tell us everything. And certainly we don't have a lab for every problem. So of course, labs are important, but there are many conditions in which laboratory data is not terribly helpful or will not get us the answer. Just again, understanding that certainly we are not, at kind of all-inclusive knowledge of biology or our bodies or disease. There's a lot that we don't know, right? And a lot that's yet to be discovered. So early intervention, I've kind of hit this a couple times, but again, this is one of the biggest kind of principles of this clinic is no, I'm not going to wait for something to go wrong with you, right? And we are going to sort of approach your care with an attitude of, great, you're healthy in every category. How do we maintain that, right? Are you doing the things that ensure we're going to meet these centenarian decathlon goals, right? Again, so just demonstrating that I believe that everybody needs primary care, good primary care, right? Not just the people who are sick, right? This program is not intended just for those folks that might need a little more hands-on care. I do think there's a great value here for folks that are kind of wanting to ensure that their long-term health has someone, again, I would just say that I could definitely be a reasonable partner with patients who are already healthy to talk about how to increase health as well as how to maintain that health, and thinking about a way to hit each one of these arenas, considering some of those future goals, okay? For those patients who are maybe already dealing with many health problems, again, I really feel like there's never a time too late to start with a lifestyle change, okay? There are numerous stories of 80, 90-year-olds, right, starting exercise programs, starting a weight training, program, increasing their VO2 max, increasing their functional capacity, so again, I think this is absolutely possible, right? Is it going to be possible for every single patient? Probably not, right? But I would say that there is a sort of maybe cultural attitude almost of ageism, right? That after a certain point, it's not even worth trying. And I just don't think that that's supported by any data at all, okay? And so again, just to really reiterate that, no, it's never too late to use your lifestyle to make a healthy lifestyle change. It's never too late to do that and still see very prominent, progression, okay? And I think I've hit that last one several times, just declining, again, counting for that decline. So now I'm going to go into each one of the four horsemen just briefly. And like I said, this is sort of food for thought, just to kind of get the juices flowing. The plan is to definitely go in depth about each one of these categories. So again, if you're leaving here feeling like I sort of brushed over these, just don't know that I will definitely go into depth with each one of these topics with future presentations. Again, number one is our atherosclerosis, cardiovascular, right? So Three main things that are driving this disease process. One is time. Okay, so the longer you've been alive, the longer that this can develop in your body. Number two is specifically your ApoB level, okay? And that is, again, something that I would say many people don't even assess until after you've had a heart attack, okay? And it's something that is a part of my yearly lab panel for all of my patients. And then inflammation, right? So this gets thrown around as sort of, and you can see I put it in quotes there. And I do pick a couple of specific inflammatory molecules in the body that seem to have very good correlation with risk of disease. Things like cardiac CRP, cysteine uric acid. There's probably more out there, but again, at least diving into that arena a little bit. And the pathway by which this is working is actually, so the inner lining of your blood vessel is one of the most important kind of structures here, and that's called the endothelium or endothelial layer. Very active kind of monitoring layer of the blood vessel. And when we talk about inflammation, what we're actually getting at is anything that causes that layer to become disrupted or sort of dysfunctional. What that allows is that cholesterol particle can now slip through that layer and get into that muscular wall of the blood vessel where it's not supposed to be, and that is exactly what atherosclerosis is. Okay, so you can see how those components sort of work together to cause disease. Something that I do that, again, I think certainly I'm very happy about sort of the status of this test here in this town, called a CT coronary calcium score. This is a $99 test offered at St. Thomas More at a cash price. This is a component of basically assessing atherosclerosis. So everything else I do with the lab work and your family history and everything else is really assessing risk, whereas the CT actually tells me how much of the disease has developed in your heart to this point. Okay, and again, using some of these tests in conjunction with your risk factors before you have an event, I would argue, is a better policy than to do these after the fact or after you've developed chest pain or something of that nature. And then I put a versus angiogram. So basically you can do a CT scan where they use dye and actually relight these arteries up with dye. That's a little better test, but I just kind of put that out there as sort of what's available to assess this disease, right? Again, some of the unique things that I think are missed in some of our primary care settings are some tests like this. And then a couple other things that you'll see as common themes that drive all of these diseases, or most of them, specifically in the cardiovascular world. Tobacco or any other, kind of nicotine products really drive this disease to quite, high relative risk, as well as insulin resistance, right? So people sort of maybe know that connection between type 2 diabetes and heart disease, right? But even those folks that are starting to have pre-diabetes, any form of insulin resistance, what we see is that high insulin levels absolutely drive this process as well. Okay, and then processed food, right? So, and those two things may be connected there, but there's been a lot of, and this is mostly epidemiologic data, showing that the communities around the globe that have somehow sort of escaped the arms of our processed food industries. So a lot of these are like in the Bolivian Amazon or, some places like that, right? They're eating, some of these, people are eating all potatoes all day long, right? So if carbs were causing heart disease, we would think that would, we would see high prevalence of heart disease in these communities. And actually what we see is that heart disease almost doesn't exist. And now part of that is that a lot of people are dying of accidents and other minor infections before they can get heart disease. But even then, in their older folks, they're not necessarily getting heart disease. And they are eating a lot of times like just plantains, rice, and potatoes. Okay. And so directly from that data, there's been some nuanced studies that have really shown that maybe processed food, independent of its macro, so what it's made out of, how many carbohydrates it has, right, might be driving some of these diseases, again, independent of their actually calorie and, carb, fat, protein contents. Okay, so what I'm getting at here is single ingredient foods much better than in foods that have a list of ingredients that you don't even understand. So cancer. So how is it that we can have a proactive approach to cancer? Right. I think, again, one of the big principles here is Maybe we are not able to prevent cancer. Part of this is just luck and genetics, right? But I do think that we can do a better job at trying to detect cancer early. Where I differ maybe from some other, actually just the national guidelines is, certainly on colonoscopy. So colon cancer is one that I think is readily findable and readily treatable. And if you have a clean colonoscopy, people these days, the guidelines suggest repeating that in 10 years. And what we're finding is that more and more people on those 10-year repeats or even on their initial colonoscopy are showing up with advanced cancer. Okay. And so again, the myth here is that this is too expensive. Okay. That we can't do a colonoscopy on everyone every 5 years. Okay. I'll tell you right now, in this town, through my clinic, right now, I charge nothing for your colonoscopy other than your membership fee. And if you had no insurance, then booking you at the surgical center, using their anesthesia, using their equipment, everything all together, we're talking about maybe $1,200. Okay. So again, you weigh that against the cost of chemo, surgery, etc., the threat to your life, right? The anxiety, etc., that comes with a cancer diagnosis. I don't know who would tell me that that is more expensive, okay, to do the prevention, I mean. So again, I think that some of that is a myth, right? And some of that is sort of, we have given up our power over whether that's expensive or not to the insurance companies, right? And they have just made a population-based sort of risk model to save their money, right? And they don't care about your personal health. They care about their bottom line across their, whatever, 15 million patients, right? So again, how is this a little more personal? I'd say that's definitely a way. If the patient and I both agree that, sure, we want to do your colonoscopy every 5 years, regardless of whether it's clean or not, again, you can do something like that through this clinic. Mammograms and other imaging, right? So we know mammograms are sort of best for fatty breasts, and ultrasound is actually much better for glandular breasts. Okay, and this actually does not in any way correlate with size. Okay, so cup size does not tell you whether you have more fat in your breast or whether you have more breast tissue in your breast. Okay, so when you get a mammogram, often they'll tell you, hey, the false negative rate is so much higher because you have glandular breasts. Okay, and then insurance companies don't cover the ultrasound. Okay, so again, we have the option here, right, to add on breast imaging dependent on your specific breast architecture and family history, etc., right, to do mammograms and then add on whatever we want, right? And we don't have to sort of be subject to these risk-based population cost-saving kind of models. Rather, we can really do what is right for you, your history, as well as your wallet. I mean, medical care does cost money, so I do want to acknowledge that yes, I mean, these aren't free tests, and I certainly understand that many people are not always able to afford all of these tests. But again, at least it's transparent, it's honest, you can make that decision. Sometimes with insurance, you have no idea what that bill is going to be. So at the very least, I can say that there won't be surprise billing out of our office. Okay. And then we do have some kind of up and coming exciting things like genetic testing, liquid biopsies, some other things there that I'm very aware of. Whole body MRI is one of those types of things that is coming to Denver, hopefully this year. So again, just the availability of some cutting edge things that maybe other clinics just aren't as interested in because they're non-billable. Okay. And then kind of just a recurring theme here, tobacco, obesity, insulin resistance are the three main lifestyle factors that really drive cancer. And so just making sure that we talk about those things in relation to your specific health. Neurodegeneration or dementia. So about 10 or 15 years ago, it was basically taboo to say that prevention was even possible in this category. Okay, and things have really changed over the last 10 or 15 years due to a couple really revolutionary docs in this field who really felt that that was wrong. And my main message is here, prevention is possible. You can absolutely do some things in your life to try to keep your wits about you. Okay. There are some genetic tests that can tell us about this risk a little bit more deeply, namely like an ApoE gene allele test. So, and again, we can talk about this in specifics with during appointments, things like that. But what we've realized is that exercise is probably the #1 prevention tool for diabetes. Or sorry, not diabetes, dementia. And that exercise literally releases brain chemicals that tell your brain to grow new brain cells. There is data now showing that people in their 50s, 60s, 70s can literally grow brain volume. Okay, so this kind of myth that once your nerve cell dies, it's gone forever, brain cells gone forever, is absolutely a myth. That's definitely been disproven. And again, exercise is one of the strongest signals that we've found to release this brain-derived neurotrophic factor, BDNF, which is what is stimulating neuron growth in the brain. Other components of life that are really important here for brain health are going to be sleep. So that's definitely up there. Neuroinflammation, again, I've sort of talked about inflammation a little bit. And allowing your body to recover from stressful events, okay? So insulin resistance, again, yes, again, this seems to be driving dementia here. So avoiding insulin resistance. Lately there's been a trend of people kind of referring to Alzheimer's dementia even as type 3 diabetes, right? Further illustrating this kind of connection between things like insulin levels, actually your lipid profiles, cholesterols, which ApoE is actually a cholesterol gene, and things like dementia. Okay, so again, just realizing that all of these things are connected, that when you're doing kind of good in one arena, you'll actually, kind of affect all these other arenas of your body. So finally, insulin resistance. Okay, our metabolic dysfunction is what I put on that first slide. Again, root cause of type 2 diabetes and what they are now calling metabolic associated non-alcoholic fatty liver disease. Traditionally has been called non-alcoholic fatty liver disease, right? So insulin resistance basically means that you're overwhelming your body's ability to really manage the intake of energy. Okay, so we all intake energy. Much of that gets converted into blood glucose or blood sugar. Blood sugar cannot be used as energy. So then basically the body, once it detects that blood sugar is there, releases insulin. The insulin then allows your body, and specifically your liver and muscles, to take most of that blood sugar up and turn it into something called ATP, which is really the cellular form of energy. So what happens in insulin resistance is that as we kind of overconsume, what the body does is it detects the high blood sugar and releases more insulin. Then within these cells, it detects, okay, we have enough, we've stored as much sugar within the cell as we can. We need to start shuttling energy into fat stores. As the body converts sugar into fat, it will actually sort of accumulate some of that fat within the cell. And what we found is that that intracellular fat accumulation makes it harder for insulin to do its job. So then a higher level of insulin is required to keep your blood sugar at the same level. One thing I kind of missed saying at the front of this is that one of the biggest drives in your body is to maintain a steady level of blood sugar. So a lot of our systems are tailored to detect blood sugar and then react to that blood sugar, right? And that's one of the main purposes of insulin. So what happens when you have insulin resistance, right, is that for the same level of blood sugar rise, you're having to release more and more insulin out of your pancreas, right, because your body's working very hard to try to make sure that doesn't go above a certain threshold. Once that becomes the case, where it is surpassing a certain threshold, now we can detect that on an A1C. And you can see that this process has probably been going on for at least, I'll tell you, and most people, maybe a decade before that A1C change is evident, okay? So I'm one of the only clinics I've seen that tests the fasting insulin, okay? And everyone, lots of people get A1Cs, but what I'm here to tell you is that if your A1C is changed, you're 5 to 10 years behind the ball, okay? And so again, kind of that early intervention, assessing this at an early stage, right? Why should a young, healthy person maybe consider a program like this? You would have no clue except through blood work if you have insulin resistance, if it's early on and mild, okay? And even then, sometimes it becomes hard to detect, okay? But we definitely have some clues through things like blood work. And I would say that this category, unlike some of the other ones, you can have some unlucky genetics, and certainly genetics plays a role here. There are going to be people who can tolerate hundreds of grams more carbs maybe a day than others. And again, that's part of just really kind of leaving the emotions out is what I'm getting at there. Lamenting that me at this level, my A1C is terrible, and whoever, and brother, sister, friend can eat cookies all day and they're doing fine, right? Focusing on that is exactly the wrong thing, right? That's the emotional aspect of it. I feel that way too, okay? But sitting there and perseverating on that only leads to more destruction of your health and mind, right? So I'm just saying, if we detect this through data, right, let's try to leave those things at home and just talk about what is it that we can do to your body, right? Again, staying personalized, not trying to compare yourself to others is sort of what I'm getting at there. And that I do think that, again, when we're talking about prevention, right, what are the tools we have? Nutrition, movement, sleep, and stress management are all involved in the way that insulin signals throughout the body. So just realizing that, yes, we can do much more than just medicine, or even just diet and exercise, right? That if our sleep or maybe our stress management is way, not where it needs to be, then sometimes targeting those things makes the others easier, and then you finally get some traction. Okay. So what is the toolkit that we have available to us, and what are the types of things that we will talk about in our appointments in specific detail, how to apply to your life to improve these things, right? So this is exercise. Some examples, again, I've touched on a couple of these, but when I talk about the exercise category, we always have to account for a couple things. What's your zone 2 look like? And maybe you throw VO2 max in there too. Do you do any form of strength training? What are you doing to maintain some muscle mass and strength as we all age and lose these things just due to time, right? And stability training, right? Something that maybe doesn't even get talked about in some fitness circles, right? So are you doing things to make sure your breathing pattern is healthy, that your diaphragm is healthy, that your core is stable, that you're protecting things like your back and your knees, right? And how is it that we can have a program of what's called prehab, right, rather than rehabbing once we have an injury? There are ways to ensure that when you maybe do have an injury, that is short-lived, or maybe that injuries happen much less often because of the way you train and think about things like core strength, foot stability, breathing patterns, right? Other things that maybe don't get looked at in that exercise category. Light and dark, again, big tools available to us all, okay? We live in sunny Colorado, which is magnificent, right? We have great sunshine throughout the year, a really big tool that's available to all of us. Again, we're circadian beings. We have specific cells in our eye that are absolutely designed specifically to detect things like sunrise, sunset, the total amount of light you've been exposed to during the day, at night. So again, kind of obvious here, but maximizing light during the day, minimizing light at night, maybe trying to view sunrise and sunset. These are probably 4 very important signals that everyone should try to accomplish in their life every day, and certainly is connected to a lot of other health processes. Social interactions, again, these meetings, I plan on having some group meetings for chronic diseases where people can kind of share their experiences. Maybe, again, we all get to learn from each other. Maybe we have some fun. Maybe you get a snack. Okay, so and again, not just about health issues. Like, I would like to also maybe do some fun things with our community and our patients as well, right? So maybe we'll have some musical events or other forms of human expression, right? So just giving people that opportunity right through this office to interact with other like-minded people in their community. Of course, I'm a doctor, so it wouldn't, I would be remiss if I didn't at least mention things like exogenous compounds here. And I kind of put that all into one category, right? So I think that sometimes in people's minds, we draw unfair lines around something like a vitamin, a supplement, and a medication as these very separate pools of things. And you see there that I've lumped them all into one, because I really think of them as one category, right? Anything you put into your body affects the way that certain biological processes are happening, maybe gene expression. It doesn't matter if it's, quote, natural plant derived, right, versus a drug or prescription drug, right? And in fact, I'll kind of point out here that the supplement market is highly unregulated, right? And that if you're sort of talking about, and again, you could tell me, hey, I don't trust the FDA, blah, 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 and I have nothing to say about that, but at least they're supposed to be ensuring that what bottles say they have in them is what's in them. And again, I'm not going to get into the debate of whether that's true or not, but it's very true that supplements have no regulatory body over them, aside from people they pay to put a label on their bottle, right? So the labels that you see as organic, even good manufacturing practice, which is a label I actually do look for, right? But again, I realize that the way that label got on there is that that drug manufacturer paid somebody to come out to their facility and put that label on their bottle, right? So again, just kind of I'm not, again, saying that's nefarious. I'm just saying that is the case. So anyway, so that's all I'll say there. Nutrition. Again, I think nutrition is, we all have to eat. It's a very, very personalized kind of thing here going on with nutrition. Some of us have specific food intolerances, allergies, etc. Right? So again, just looking at what does that look like in your life and thinking about how can we make sustainable changes, right? So fad dieting, again, something like that is what I'm sort of against in that comment, right? So thinking about what can I do for the rest of my life? I hate the word diet because it implies that it's going to be temporary, right? So if we think about more like sustainable small changes, I think that's a little smarter way to go about it. Mental health and stress management. So again, huge array of tools here, something I'm very personally passionate about. And again, I think we actually have a lot of cool resources in our community, and certainly I can act somewhat as a mental health provider for many people too. And then we do have our health coach here as well, who certainly can be another tool for both of those things. And then sleep again. So realizing that sleep is an absolutely fundamental biological need. There is no way around that. It doesn't matter what you feel like, that you feel you can get by with 4 hours of sleep. I would say there's a vast amount of data really supporting that your health will be impacted at that lower level. Again, there's some gray zone there, but there's definitely some intervals, probably close to 6 to 7 hours. Almost nobody can get away with less than that and not have any health impact. So that's kind of the toolkit there. And again, kind of food for thought and topics to sort of dive into with future discussions and certainly at personalized visits. And where's my mouse? There it is. So how is it that you can utilize us to help you, guide you in some of these things, right? Again, this educational series. So again, I hope to have hopefully one of these a month, and hope to kind of hit some of these high yield topics, which I've sort of skirted, touched on briefly here today. One thing that's unique to us, I think, even from other direct primary care visits, is maybe having these group visits, right? So that ability to share your knowledge, or maybe even barriers, right? Hey, I'm running into this problem. Has anyone else experienced that? I think that has a lot of value, right? So having those group visits. Text and email. So just wanted to kind of point out, right? So most direct primary cares offer text and email. And I just think that this is a really important tool, right? So many people kind of tell me, well, I'm not going to bother you, blah, 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 this, that. And it's like, no, that's the exact wrong thing to do. Okay. I'll repeat kind of my one-liner here. My job is to manage my time. Your job is, as a patient client, is to let me know when you need help, right? So that is the agreement here. I do want people to, quote unquote, bother me, text, email. Again, even non-urgent issues, great. Send an email. If it's urgent, then maybe choose text, okay? Or if you just like to text everything, that's fine too, or email everything, that's fine. Okay, but I'm just encouraging that back and forth conversation. Don't wait till your 6-month follow-up to tell me your shoulder's been hurting for 6 months, right? Again, that's the purpose of that. I don't read minds. You do need to tell me if you need help. And it is, don't worry about the time of day or what kind of time it takes away from me. That is literally my job to manage that. Okay, so just repeating that there. And then health coaching. So this is a new member of our staff that many of you may have met. Her name is Carolyn. She is sitting here in the back. and she is got a certification in health coaching, and specifically with some nutritional interventions. So if my patients feel that they need some additional support, maybe would like someone to call and do some outreach and develop some specific plans around eating, exercise, sleep, etc., right? We really brought her on to be additional support for my patients and to really get into some of the nitty-gritty details, or maybe just to be kind of someone to talk to, or a shoulder to cry on. Okay, so all of that for whatever the situation entails. Advocating for yourself, right? So this is super important, right? Again, healthcare isn't something, health isn't something someone does to you, right? You have to do something to be healthy, okay? And I'm just kind of pointing out that this is a partnership, okay? It's not, I don't have a magic wand. I can't overcome, certain things. If you're never going to exercise and eat Cheetos all day, I cannot overcome that. Okay, so again, just advocating for yourself, and then sort of another corollary here would be some people I know have had less than ideal responses from their providers when asking questions, when asking for help, when sort of pointing out, hey, this seems like that's not quite right. Can you just verify for me, etc. Right? And I want to just kind of put out there that if I ever respond in that way, maybe I'm having a bad day, and please let me know that, because my intention is to always hear out what you have to say and to always be available to answer any questions. Now, I do reserve the right to not know the answer, so I'll just tell you that on the front end. But I would, if I'm ever making you feel like a question is a criminal event, then please let me know, because that is never my intention. And what I'm trying to build here is a place where people can feel safe to come in and ask their questions and not feel like they're going to be scrutinized for that. Okay. And sometimes patients, again, I've had multiple situations where patients recognize that, hey, maybe this was the wrong medication choice, or we made an error on dosing, or other things like that. Again, I'm a human being. I'm never going to be at a point where I don't make a mistake. But again, if you feel like a mistake has been made, absolutely, I want you to tell me. Okay. And I want to have that relationship with my patients. Again, one of the things that I'm very big on, as you can probably tell, is that the decisions we make are collaborative and shared, right? I do not want to be your decision maker. I'm not your father, mother. I don't tell you what to do. Okay, I'm an educator, I'm a partner, I'm your advocate, but I am not your authority. Okay, so again, I want, if people ask me, hey, what would you do? Sure, I'll give them an opinion. I'm not going to waffle and never tell you clearly what I think we should do. But at the end of the day, I want people to hear that that decision is always with them. And if they decide otherwise, then I will always defer to the patient. Okay. And again, give you an opportunity to share ideas and to be a deeper part of this health community, to share sort of your successes and failures, not just with me, but with maybe other people suffering with things that you're experiencing, right? Or maybe to come here and get that knowledge, right? So I'm hoping that these sort of settings and having that flexibility, not being tied down by some of the rules of insurance and HIPAA, right? As long as you feel comfortable sharing, I'm not going to force anybody to share anything, but if you feel comfortable, then again, we're sort of free of some of the red tape that makes that hard to do at other clinics. Okay. Just a quick note here on kind of the system differences, and this is a little bit more catered to any interested patients that rather than people who are already members. This probably won't apply too much. But yes, I have many people tell me, well, now I have Medicare, so I can't keep you as a doctor. And that is false. You can. Okay. You may choose to not pay my service fee, and that is fair. You have your choice in your healthcare. Okay. But yes, you can absolutely maintain any and all insurance programs with the exception of Colorado Medicaid. If that is your primary insurance, then we will bill your insurance company. That is the only insurance contract I have. And that actually is only for my current patients. I do not accept new Medicaid patients at this time. Okay, so if you have Medicaid, yes, we're billing your insurance. For everyone else, you can maintain private insurance, Medicare, whatever is VA, except TRICARE. You can have all of those and still be a member here. Okay. Yes, you can choose to use that insurance policy or to use my policies. Okay. So I have specific policies with Park West, with LabCorp, with some virtual consultants and things like that. But if you would prefer to use your insurance for your upcoming CAT scan, or maybe we have a cardiologist or neurologist, whoever that's involved in your care, absolutely, you could still use your insurance exactly the same at all of those clinics. So being a member here only opens the door for more options and potentially some, cheaper prices through non-insurance vehicles. But again, if you got great insurance and all of this is covered, wonderful. Okay. Certainly this does not restrict you in any way. Just a quick note on Medicare's donut hole. I'm just kind of pointing out that nothing I do hits that Medicare deductible. So oftentimes you may choose to get certain medications or tests or other things like that to manage your deductible and kind of other considerations. So in a way, I would say, yeah, primary or coupling direct primary care with your insurance may allow you to actually use your insurance more effectively and still end up at a lower price point. Okay. Many patients who come in have asked the question, like, do I need to maintain an insurance provider? And I'd say the answer is no, in almost all cases, right? I can do anything and everything through your insurance, the same as an in-network provider in almost all cases. If the situation arises where they have to have an in-network provider ordering a certain test or procedure or whatever, we will navigate that case by case and figure out the best way to make that happen in your care. But one of the things that, again, we're not kind of privy to is all of the rules of insurance, right? So there's a lot of unique things that I can do with this clinic. I listed a couple of those. I'm technically not under the auspices of HIPAA. That's not to say that your information is not taken very privately or securely, right? Just that actually what that means is I don't have to transmit your insurance to your healthcare company. So in some ways, you could actually argue that it's more secure and more private. Okay. Anyway, so just kind of getting that insurance bill, right? Each time you come in, that's sort of an episode of care. There's a bill that's associated with that. Whereas here, right, if you come in for a quick exam or other things like that, there's no additional billing there. You've kind of covered that with your sort of retainer fee or monthly fee that you pay our clinic. Okay. So just to kind of touch on some of those. Okay. And that's basically what I had for you guys today. Obviously, really appreciate the people that are here in person, the couple that are signed on online. Anyone's viewing this later online, thank you for your time as well. We do have a Facebook page, a website. We plan on maybe using some things like some monthly emails, other things to just kind of pique people's interests, kind of put out, important messages, things like that for, dates for these sorts of presentations should be available on all of those resources. And just looking forward, as I've mentioned a couple times, what are some of the things that we'll kind of deep dive into over the next few months and years? Some of the high yield things, again, metabolic health, insulin resistance, managing pain, cancer screening, mental well-being, weight loss. So many of these things that we can definitely do a whole hour on, and we'll plan on doing that. And I do take, again, this is supposed to be catered to my population. So if people out there really want to hear about a topic, again, have questions or something, or have a request, you're welcome to submit that through email or text. And I absolutely will, use my community's desires to guide where we go with this clinic. You guys are funding me, and I want to give back to the community what it is that they're looking for. So yeah, that's what I got for you guys today.
Cool. Yeah. Good job.
We got any questions? I'll turn this up a little bit so I can hear online too.
You were talking about the max VO2.
Mm-hmm.
How is that measured?
Yeah, so how is a VO2 max measured was the question. So the gold standard is to put you on a treadmill or exercise bike, put a mask on you, and collect gas. So literally it measures your exhaled gases. Okay, there are some calculators available, so you can do certain types of like exercise protocols, and based on like your time or distance or other age, other demographics, you can sort of put those into a calculator and calculate a VO2 max, right? And even like I think Apple Watch and some of these new fitness devices will sort of give you that readout based on some exercise statistics, right? But the gold standard is absolutely blood gas measurement, okay? And that is something that you know, I hope. So one of the things that this system allows me to do is to really have the financial resources to expand my in-house services. And I'd say bringing VO2 Max in-house is certainly one of my goals, okay? If not, maybe partnering with the local gym or something like that to where we can share equipment and cost, right? So, but yes, making that testing available in town is certainly one of my goals.
I assume from what you just said that it's not currently available.
I'm unaware of anyone that does the gold standard blood gas testing. I have a handful of people I know who have gone to some facilities in Springs that do this type of thing. They're generally going to be like kind of athletic performance type facilities. So this is usually something more in that sports medicine or sports assessment kind of world. So obviously Colorado Springs has like an Olympic training facility. There's plenty of places to get this done in Springs, just not here. So.
And then explain again what that means in terms of the overall health.
Sure. So, you know, as far as predictive modeling goes, this is one of the most predictive things as far as future longevity and health, right? So the higher your VO2 max, what we see that those people, age adjusted, live longer from that age, right? So let's say your VO2 max at 90 is at the upper end of 90-year-olds, right? You could very reliably tell that person that probably you've got several years left in the tank, okay? Whereas if someone was like 70 and maybe their VO2 max is lower than this 90-year-old and low for a 70-year-old, right? You could sort of tell them like, look, right now at your current status of health, right, this is a very poor marker that, you know, if you take a big hit, like, you know, an event of some kind, that may be the difference between life and death, right? So it's sort of a stress tolerance type of marker, right? But, and again, it's an association, not causation, to be clear, right? These are associations between mortality and VO2 max, right? But it's such a strong association that it's very hard for, you know, most people to really say that there's probably not causality in both directions, right? So high VO2 max sort of indicates that you're already in good health, right? But also it's sort of, you know, how did you get there, right? You probably lived a healthy life, right? Which also means that in the future you'll be healthier, right? So it's kind of it's all mixed into one. So,
but it's also something that if you've got low VO2 max, you can improve.
Absolutely. And we do believe that that is sort of a marker that your overall health has improved. Yeah. Because what it's telling you, right, practically what it's definitely telling you is that you're able to consume more oxygen and generate more power as a result, right? So your kind of cardiorespiratory system, along with sort of metabolism, mitochondria, these are all involved in this process, right? So it's a functional measure of all of those things and how much power output can you put at, you know, kind of maximum. But again, it's just right. So a lot of people will say, go exercise, eat a healthy diet, right? And maybe your diet may be more telling, right? Because if weight goes down or something like that, maybe you know you're doing right. With an exercise program, right, it's hard to sometimes know, like unless you're doing some real, you know, tracking, it's very hard to know, like, did I get more fit or not? Right, and that's where things like zone 2 output, VO2 max, are at least like nice objective numbers that you can then say, okay, over the last 6 months, I definitely have made improvement. It's very hard to know. Like, do I feel better than I did 6 months ago? I don't know what I felt like 6 months ago. Like,
Exactly.
So again, just having some of these measures just help all of us sort of know what we're doing is working.
Right.
Yeah.
So you were saying like in your 50s you would grip or do things to
Sure.
keep, okay. I didn't do that, but I swam 45 minutes or an hour, you
Of
know,
course, sure, excellent.
laps till I hit my 70s and started getting these problems. So would that be like the same thing as doing the gripping and
Yeah, I mean, I think any movement is going to definitely have positive effects in your overall health, you know, over time, you know, so, but, you know, what I was getting at there is sort of just another objective measure that has good data behind it, right? So I can't look at your blood count and tell you, hey, you know, you're in great health, right? I mean, it's your kind of normal pattern or not, right? Whereas if I look at a grip strength and say, hey, you're at the bottom 10% of your age and sex, right? That's a real functional measure that then we can actually do something about. And then I can sort of say, like, as grip strength improves, what that's really a marker of is that your arms, your shoulders, probably your whole upper body is probably much stronger. Okay. And then there's sort of this neuromuscular component of this too, right? That maybe it's not even the intrinsic muscles, but if we're not using those nerves, you know, pathways as much, then sometimes there's degradation of the actual nerve signal, right? So there's two components of this, right? And so again, grip strength is not the end all be all, right? It's sort of a marker of some of these other things, and it's just easier to measure than doing EMG on your nerves, you know, so yeah. Any questions from online? Everybody doing good on there? Okay, I think so. So I'm gonna go ahead and at least stop the recording. Let's see here.